Can everyone hear me? Okay, great. Okay, so the housekeeping, fantastic. It's really funny when you talk into the depths of Teamsness, isn't it? So I hope by now we're all fairly familiar with webinars, and that please use the functions. We will have your cameras and mics off, just obviously as you'll probably be used to by now. Just to enable there to be enough bandwidth for everybody to be able to join. And if you need captions, please do turn on the live captions. I will, myself and all our speakers will try and speak clearly so that the captions work for you. Next slide, Rebecca. Sorry, the slides are going quite slow. So please do also use the chat settings that you've got, and you can get more accessibility features through that if you require them. We'd also like to note that we take a trauma-informed approach to our webinars, and that you might find content while we have no intent to do so, and have managed it, so hopefully it's not, but for all of us, we have our own personal experience. If there's anything that you find uncomfortable or you're not keen with, then don't obviously hesitate to leave and take the time you need to look after yourself. That's the most important thing, that you look after yourself within this session. I will just try and adjust that. I'm Diana Heckerham. I'm the Associate Director of Transformational Change at Healthcare Improvement Scotland, and I'll be taking you through this session today. If there's things that you would like to raise with us, then please either put them in the chat and email. If you're not comfortable with sharing them in the chat, then please just do use the email function, and we can get back in touch with you directly. So I think I've taken us through our housekeeping now. I'm delighted that we're going to have a range of speakers today. We'll be hearing from Rachel King, who's our unit head for transformational for mental health here at Healthcare Improvement Scotland, and she'll be giving you the detail on the mental health transformation programme. We're also delighted that we've got two speakers with us today. We should hear from Ian and Ruchika. Ruchika is the Senior Research Fellow and Clinical Psychologist in NHS Greater Glasgow, and Ian is the Professor of Child and Adolescent Psychiatry in NHS Lothian. So delighted you'll be able to hear from both of them. Our clinical lead for early intervention and psychosis work, Susie Clark, our clinical psychologist, is also with us today and will be part of the Q&A at the end. So first of all, I just wanted to bring to you an oversight of why we've brought together a mental health transformation programme. In the past, we've had several programmes that have worked around looking at different models of care for mental health in Scotland, and these range from early intervention like psychosis, personality disorder, looking at coming home. The reason that we've brought them together in one mental health transformation programme under the title of Reform is to stand alongside our patient safety programme. So our mental health patient safety programme looks at point of care improvements that improve the safety and reduce the harms for people who require services from mental health teams. What we felt was that the reform was important to bring together as this transformational space where we're looking at how, particularly across our integrated space, we can think differently about delivering our mental health, and allows for the shared learning, not from the importance of the different clinical and care operational detail of different models of care, but what is consistent and clear about working in reform. So if you can move slides, Rebecca. So for us, it all starts with a quality management system. This is hopefully something that many of you are familiar with. And the quality management system asks us to do a few things. At the heart, it talks about the planning for quality. And that's really important when you think about that from a co-design and co-production space. And we use a lot of our service design methodology for this. That co-design and co-production space means that planning is thinking about with people who deliver services, with people who need services, and people and their families who are using services, that we understand what quality is for them, and that we use our evidence base to understand and learn what approaches we can take that will deliver an increased quality of outcome for the population. Our improving quality is to use a range of improvement methodologies to support the implementation of that learning and understanding, and from that planning. So how do we actually implement and put that in place? And our maintaining quality enables us to measure and monitor that quality, and importantly, to do so in ways that bring people and their qualitative experience alongside the data and intelligence as we build that. And that learning system right there at the heart really informs our approach, that this is not, we don't take a performance management approach, but really try and bring that richness of learning so we can make changes to business as usual in our system. Next slide. But within the reform work, we understand complexity, and we really recognise that we're working with two really critical things, that we have people who require mental health support in these services, such as early intervention and psychosis, personality disorder, CAMHS, learning disability support services, that people's lives are complex. So this is an obesity map, but it applies to a myriad of conditions. But this is when you take lots of people interested in public health in a room and make them map the causal things. If you've not seen this before, I find it joyful. What you will see within it is that there are a few factors of the 108, those ones highlighted in blue, which are health and care treatment options. So people's outcome is not a direct result of those four things. There is a direct result of that interconnection with their wider context and their wider life. And that's what's really, we really see as the critical part, and really the success of those models, such as early intervention psychosis, is that they attend and recognise that people are complex individuals who require holistic, multidisciplinary support in really collaborative ways to achieve those outcomes. Next slide. But what we also know is that that then works within a complex adaptive system. How we operate across across these collaborative partners with colleagues with occupational therapy colleagues, with third and independent sector colleagues, a lot of the community resources, a lot of the specialist clinical input, a lot of employment support, a whole range of things work within that, and that there isn't a single solution for every individual. So we also try and build in with this work a management approach enables connectivity between which doesn't assume that that if you apply A rigorously enough, you will always get B. That looks and understands that we work in a messy, messy world, but does apply, and we bring the kind of tools and approaches that enables us to understand how to create some structure and order within that messiness, while not living in the sort of delusional space that if we rigorously do A, B will always follow. Next slide, please. Because what we understand is when we build a system around linear processes and about making efficient use of individual resources, what we end up with is a workforce that kind of wrestles with why it's so hard to do what intuitively feels right. That we know that where we're working with these new service models, the well-being job satisfaction, but really that well-being, that staff well-being and motivation for their work, when they feel that they can meet people where they are and deliver for them what they need, rather than being so constrained by our traditional silos and barriers. So within our reform programme, we look to how we can support a system to adapt to be able to do what intuitively feels helpful. Next slide. And what we've learned from is a range of things that we need to apply behind our clinical models that will enable this different way of working, the holistic, person-centered way of working, to really thrive. And that's what this sort of approach is what will be behind all of our reform programs. And it allows us to think to how do we govern and have systems and processes that recognise we work in a complex adaptive system? How is our leadership style not a siloed and respecting the efficiency of an individual service, but is that collaborative and wide learning approach? How do we use, which tools do we use, and methods that we can bring, such as service design tools, journey mapping, some of those wider tools, but also how do we apply the learning when we've done something such as demand and capacity analysis, to understand that that is an insight into how a system functions, and not a thing that tells you something's right or wrong, but enables you to adapt. It brings together commissioning approaches, which take us from a transactional relationship with our community and third sector partners to one that is really relational and understands that the learning that we need to be able to continue to adapt and improve comes from a relational commissioning space, and a commissioning space that's based on people and relationships and partnership working at its heart. That in our evaluation, that we will look just not at the efficiency measures and the productivity measures, but really understand the wide whole system impact and people's quality of life, and people being sustained into long-term employment, people being sustained into being the best version of themselves, and that comes without any judgment of what that means for the person, but that we can evaluate how well the models are able to do that, alongside the economic evaluations of how they bring whole system efficiency under our strained financial challenges that we've got. So it doesn't ignore that we live in these challenging times with difficult finances, but it allows us to think about that in a more holistic way, about the public purse in its broadest terms. So when we do this, if we look at, next slide, please. So when we think about what does that mean in practice, what we've seen and understood from, within the looking at the impact that the early intervention program had last year, we can see that you can have really holistic, positive outcomes with people back to employment, high levels of engagement with treatment, reduction in clinical outcome, poor clinical outcomes, increase in positive outcomes, such as people using substances stopping, because it's got that really that balance and understanding of that complexity at its heart, where carer-focused education and support sits alongside CBT, which sits alongside medicines, which sits alongside family interventions and education. And it is how we make sure that we leave a system able to sustain and develop this. But also we recognise that that service doesn't sit in isolation to a wider mental health service. So how can we, through our reform work, understand how to support the whole of mental health services to find balance, to find resources, to bring staff that positive well-being, so that we can grow and sustain the workforce and work closely with people and their families for those outcomes. So that's the ambition of the reform programme. None of that hopefully is new in isolation to anybody, but gives an underpinning as to what brings and unites everything that we're going to hold within the reform programme. And to talk through that in more detail, I'm delighted to hand over to the head of our mental health unit here at Healthcare Improvement Scotland, Rachel King.
Hello everyone, thank you Diana, and hello everyone. It's great to be with quite so many of you today. It's amazing to see so many interested people here today, and thank you all for managing the tech issues in the background. I think hopefully we've got you all with us and you can hear me as well. So as Diana's just introduced me, I am Rachel King. I am the unit head for the Transformational Change Mental Health Unit at Healthcare Improvement Scotland. And following on from what Diana was describing, I'm going to describe our approach to our mental health work in Healthcare Improvement Scotland, and also focusing on the reform programme itself. I'm assuming that many of you are already aware of some of the work that we do. You're all here today to hear more about the practice within this area, and hopefully that's what we're going to give you and describe to you how this all fits together. As Diana described, we're really focused here on looking at complexity, and as I go through the next couple of slides, if you can hold in your heads everything that Diana has just described and the way in which we're trying to make sense of the mental health system, mental health services, and people's experiences going through that. So that should give you an overview of our aim. And what I'll do now is just move on to the next slide and describe how it is that we're trying to do that across our organisation. So next slide, please, Becca. Thank you. So we have historically done work that's been about individual programmes of work. So you can see on the left there the way that we have previously in Healthcare Improvement Scotland looked at lots of different pieces of work that's directed at specific parts of the mental health system, that we've worked with individual and local teams on those specific pieces. The Scottish Patient Safety Programme, which many of you will be aware of, has had a national focus, but again has worked with individual teams from each health board. Early intervention in psychosis we've already heard about this morning, coupled with mental health and substance use, the MHSU work, which is now looking at developing a national protocol. And we've looked at personality disorder, both our national needs assessment and now to look at what would better and different look like. However, what we're trying to do now, and this fits with the national I suppose sense of direction about how we can reform, improve and change our public services in Scotland, we're looking at three main elements of our work in Healthcare Improvement Scotland. One is around insurance of mental health settings, and we'd be doing that in conjunction with the Mental Welfare Commission and the Care Inspectorate, who already have, you know, a role to play, their legislative duties to deliver there, and we'll be working alongside them to ensure that we are working together and collaboratively in those settings to look at assuring those settings. We're also looking at standards, and those pieces I've already mentioned, the Mental Health Substance Use National Protocol, which will be launching towards the end of September. And we look at a local assessment tool for the mental health secondary care quality standards that were published this time last year. So again, we're trying to get into the system to look at what is it that would assure quality, what is it that good looks like in mental health services. And then finally, what we're here to focus on this morning is around mental health reform. So that is about how can we do things differently and meet the needs of those that are not best served by the way that things have historically developed in terms of systems and services and access. So we know that we are at risk of building equity and inequality into the way that we deliver and develop systems and services. And the reform programme gives an opportunity to unpick some of that, to think differently about how we deliver, and to understand how we can best meet the needs of those who are perhaps most vulnerable for being excluded from mainstream services. The way in which we do that in reform, I'll move on to the next slide, initially is to look at these four programmes. Two of these programmes were work that we had previously been delivering and are now taking to a new phase. So early intervention in psychosis, and we have today with us our current clinical lead, Susie Clark, who will be part of the agenda today. And that work has really been developing in two areas of Scotland and will be continuing. We'll be taking on a new Pathfinder site and looking at what does different look like, and how do you adhere to an early intervention in psychosis model while recognising all the complexity that Diana described earlier, and the financial challenges and the workforce issues that we know go right across Scotland. We have our personality disorder improvement programme, and we're looking there again at working with 2 or 3 local areas to look at, well, what would different, better and improvement look like in those areas in terms of meeting the needs of people with personality disorder, in terms of staff having a different role in terms of attending personality disorder need, and in terms of data collection and analysis of that. What would that look like? So we're testing that over the coming months, and we will be able to highlight some of that good practice through our learning system. We've also got 2 other pieces of work within reform which thread right through reform and standards and assurance. One of them is focused on coming home, which is a piece that is predominantly focused on people with learning disabilities, but really also speaks to people with complex mental health support needs as well. We're establishing a peer network, and again that will be launching just at the end of this month, at the beginning of October. We are identifying good practice because, again, we know that we're not starting from zero in any of these programmes. We know there is really good practice. We know that local areas are doing training. We know that people are trying to attend and meet the needs of those that come through their doors in terms of seeking support. And we're also looking at how can we use the learning from coming home that's focused on learning disabilities and use it to make reform, change and improvement, transformation in the mental health system. And finally, a piece on delayed discharge. We're going to be working with 2 areas to look at where are the delays in discharge and what do they look like for mental health and for people with learning disabilities. This is going to be a data-driven piece of work. We're looking at the delays on a regular basis, but we're also looking at what would need to change both locally and nationally in order to meet the needs of people better, and in order to focus on flow through the system, on preventing admission, on having good community support. So that leads us right back round to early intervention psychosis and personality disorder. So for me, these programmes, although we can set them out like this in 4 different boxes, they all intertwine and they all make a difference to the way in which we can meet the needs of people who are seeking support for their mental health. So I just wanted to touch very briefly on the ways in which we choose to work on these things. I've talked about us having a focus on inequity and inequality, and really having a focus on data, evidence and understanding local systems. The final point that I would really like to make is about understanding people's experience, being driven by, at the centre, people's experience of services. And that's both staff working in those services and people who are seeking support, and their families and their carers around them. In order to do this, we use a number of different improvement methodologies. Diana outlined earlier that because this is an area of complexity, it lends itself to a multidisciplinary approach in terms of improvement. So although you may know that we often use quality improvement methodology, we also use strategic planning to look at how do you embed and sustain change in policy legislation and in local delivery. How do you get things to be priorities? We use service design in order to be able to design both the right thing and design that thing in the right way, because each local area is different in terms of population, in terms of need, in terms of workforce, and we need to be responsive to that. And we use measurement and evaluation in order to understand how we're making an impact, how local areas can continue to make impact, and what that looks like. And one of the things that we would like to share with you today are some of the journey maps that we have supported local areas to develop that really look at the experience of people walking through their services and their systems over a number of years often, and particularly in terms of their experience of psychosis. So Ashley will put in the chat over the next few minutes those journey maps, and we would welcome your comment and feedback, and we hope that they will be a useful tool for you in order to understand better your own services and systems. If we just move on to the next slide very briefly. Thank you. So this is just to let you know about how we are thinking in terms of this work. So I've outlined that we have these 4 programs. Today, we're really focused on psychosis and personality disorder, and we're hoping that you will stay engaged with us over the coming months, not just on psychosis or personality disorder, but also to be in touch about delayed discharge and coming home. We have designed this program with everyone in mind. We have been in discussion with our stakeholders, and so this is really about us being able to deliver change on the ground with local services that make a difference to the way that we can see the future development of the mental health system. If you want to get in touch with us, please do. We've got lots of opportunities to work with local areas. We really appreciate having conversations about how we can engage with areas, and we would welcome contact from anyone on this call to follow up on anything that you've heard to date. So thank you very much for listening to the overview of that. As I've said, we're focused today on 2 parts of the reform programme, which is psychosis and personality disorder. And we've done that because we know that people with experiences of psychosis and personality disorder can experience challenge in getting their needs met in a timely and responsive way due to the system pressure, due to the financial challenges, due to workforce shortages, and due to the way that historically services and systems have been set up. So what we're hoping to do with the next 2 presentations is to give you insight and understanding about how we could further meeting the needs of those individuals and their families. Just before we begin presentations, I just wanted to mention that we would be delighted to hear about questions or comments that you want to make on the presentations. What we're going to do is ask you to pop questions or comments in the chat, and we'll be gathering those as the 2 presentations happen. And at the end of this webinar, there'll be a question and answer session, which will be facilitated by Susie Clark, but it will be after both presentations. But do pop all your questions in the chat as you hear from the speakers. So I'm delighted to say that I'll hand over now to Ian Kelleher as our first guest speaker. Ian is Professor of Child and Adolescent Psychiatry at Edinburgh University and is a consultant psychiatrist at NHS Lothian CAMHS. He will be focused on understanding psychotic symptoms in young people and in thinking through what is it that clinicians need to know about that. So thank you all very much for being with us this morning, and I'll hand over to Ian now. Thanks.
Thanks, Rachel. Okay, good morning, everybody, and thanks for the invitation to present. I'm going to tell you a bit about the research that we're doing in Edinburgh University on psychosis. And as you'll see, we're very data focused, in line with what Rachel was speaking about. But so next slide, please. Just my disclosures. This is consultancy work I've done over the past 2 years. Research consultancy, no consultancy for pharma companies, and I don't have any conflicts of interest. Okay, next slide, please. So I'll talk a little bit about outcomes in psychosis. Again, using data to look at what we know about outcomes in psychosis now. About data we have on mental health service use in psychosis. Then about psychosis prediction and prevention. It's written into multiple guidelines in the NICE guidelines and European guidelines about prediction and prevention of psychosis. So I'll talk a bit about that and some future directions. So next slide, please. So why is prediction and prevention a research priority in psychosis? And I think that there are lots of reasons as to why that is the case. There are lots of heartbreaking personal stories about outcomes in psychosis that are far below what we would like. But I'm going to focus in on on some of the hard data and what that tells us about why this is important. Next slide, please. So these are two reviews on long-term outcomes in schizophrenia. One is a very recent publication, and what those reviews tell us is that after a long, more than 100 years of treating schizophrenia, often the outcomes are still not good. So next slide, please. So in terms of recovery from schizophrenia, just 16 to 24% of people with schizophrenia recover. And so what is recovery? Recovery is when people go into clinical and social remission over a sustained period of time, usually for 2 years or more. And that means that they're having no or minimal symptoms. And social remission is about having a happy or healthy life, not being in hospital, not being isolated because of your illness. And I think we'd all agree that those numbers are not where we would like to be. We would like to see far higher levels of recovery in schizophrenia. Next slide, please. So this is a nice graph that we call it's called a mosaic plot or mosaic graph. And this is some of the hard data that, one of my appointments is in Finland. I work with also with a lot of Finnish data, Finnish register data to understand pathways for young people who come to our services, when they come, what they come for, how those trajectories look when you follow people over time. And we often lack key information about what our services do, what our clinical time is divided in. In Finland, they're exceptionally good at capturing data on a whole range of things, including their healthcare services. And so that is one of the reasons why I work a lot with Finnish data. So this is data from Finland, so the annual appointments across mental health services. And Mosaic plot has these nice colors, and it shows you divided into different diagnoses, what takes up outpatient appointment times in the services. So what you'd be unsurprised to see is some of the big blue, lighter blue square, you're seeing depressive disorders, which are extremely common and not surprising that they take up so much time. And then in the sort of pinkish purple color, you see anxiety disorders, also extremely common. Schizophrenia spectrum disorders are in green, and they are certainly a lot less common, and yet they take up, as you can see, so this entire grid, this entire plot shows 100% of the appointments. The appointments in the mental health services for schizophrenia spectrum disorders are in green. So taking up, despite being not common mental health disorders like depression and anxiety, they take up a lot of clinical time. Next slide, please. So this is the same type of plot, but this time it's for inpatient bed days. And so what you can see very clearly here is that still in green are the schizophrenia spectrum disorders, that they're taking up not just a large proportion, but actually a majority of inpatient bed days are being taken up. And so this isn't just about the numbers of admissions, this is the number of bed days. When you add them up over a year, by far the majority are taking up the schizophrenia spectrum disorders. And I think this really paints a clear picture in a lot of ways. It paints clear pictures for, from an economic perspective, of course, that's going to be extremely expensive. When I look at that picture, what I think of is lives being under-lived, or lives being wasted in hospital, and that we would like people to be in the community, leading healthy, happy, productive lives. And that's something that we need to change. So next slide, please. To put this in another way, to give it a very clear number. So these were data that colleagues in the Finnish Institute for Health and Welfare recently provided to our research team. And they looked back over all inpatient bed days in Finland between 2013 and 2023. I hope the next time we meet I might have similar numbers to show you for Scotland. But Finland, in a lot of ways, is very similar to Scotland, a similar population, similar socioeconomic status, and so on. What I haven't put labels on all of them. The highest the highest bar that you can see there is for mood disorders. So that's nearly 2 million bed days in Finland between 2013 and 2023 for the treatment of mood disorders. I'll go to the next slide, please. And you can see that when the next slide comes up, you can see for schizophrenia spectrum disorder. So nearly 6 million bed days during this period taken up for the treatment of schizophrenia spectrum disorders. And so again, it's a real skyscraper there in terms of the absolute number of days that are taken up treating in an inpatient setting schizophrenia. Okay, so next slide, please. So I hope that gives a sort of a clear indication why we would like to be able to predict and prevent schizophrenia altogether, because once somebody develops schizophrenia, unfortunately, all too often, the outcomes are far below what we would like them to be. That's not to take away from how much we can do to improve schizophrenia when somebody has it. But that, I think, is a clear picture of why we would like to get beyond that and actually to predict and prevent. And so the first question then is, well, can we identify risk for psychosis before illness onset? And that has been a big focus of research for more than 20 years, including here in Scotland, but around the world. And there have been two principal approaches that have been used to try to identify risk for psychosis even before it has its onset. So the next slide, please. So those are familial risk approaches and clinical high risk approaches. And so I'll just take a minute to tell you a bit about those. You might be aware of them, you may not, but familial risk is based on having a family member, usually a parent, with a history of schizophrenia or schizophrenia spectrum disorder. And we know that people have an increased risk of developing schizophrenia if that's the case. A lot of research on this topic has come from here in Edinburgh. Eve Johnston and Steve Laurie did pioneering work in Edinburgh on risk of psychosis if you come from a family where one of the parents has psychosis. The dominant approach, though, over the past 20 years has been the clinical high-risk approach. I mentioned just at the very start of the talk that this is written into a lot of national clinical guidelines, NICE guidelines, European guidelines, that services should be offering clinical high-risk assessments. This is sort of analogous to diabetes and pre-diabetes. You know, if you have increased insulin resistance before you develop full-on diabetes, maybe that's a time point to intervene. Similarly here, this is about having some kind of psychotic symptoms, attenuated psychotic symptoms, not having nothing fully psychotic, but having some psychotic symptoms, having some hallucinations, perhaps with some insight still, having some overvalued ideas, but with some insight as well, so that those symptoms are attenuated. And you can use a structured interview. There's the SIPs, there's the CAMHS, and you can use those interviews to assess those symptoms and rate them, and that will tell you whether somebody meets criteria for clinical high risk or not. And as I said, the clinical high risk approach in particular has been written into clinical guidelines nationally and internationally. But it was only quite recently that a data-informed approach was really taken to understand how many people at risk of psychosis does this actually capture. So it's one thing to say that people who have familial high risk or have clinical high risk have an increased risk of psychosis. Do we put all our eggs in that basket? Is this going to capture everyone who's going to develop psychosis if we develop these services? And that, like I said, those questions have only recently been answered. So next slide, please. Literally in the past week for the familial high risk approach. So this and in the past few years for the clinical high risk approach. So there are two studies here. One was done in London, one was done in Melbourne. Melbourne is the home of clinical high risk research. And what they found in London was that this was at the South London and Maudsley services, that a very small proportion of future psychosis cases were actually captured by their clinical high-risk services. So it was just about 4% of all psychosis cases. So what that tells you is that 96% of psychosis cases would not be prevented, even if we had an effective preventive intervention, which unfortunately we don't yet do, but that's something we need to work on in research. But even if we did, the clinical high-risk approach is going to miss 96% of psychosis cases in London. In Melbourne, which, as I said, is the home of clinical high-risk or ultra-high-risk research, they found that their clinical high-risk services picked up 14% of psychosis cases. So again, even at that very prominent centre, they were missing 86% of cases. And their conclusion was that other methods are needed to identify people at risk of developing a psychotic disorder. So next slide, please. So this has just been published in the past few days, actually. This was work we did in our team, led by Colm Healy, with a similar question for the familial high-risk approach. Again, we didn't know what proportion of psychosis cases this captured. So if you focus in on the familial high-risk approach, if we say, okay, let's focus on people who we know of schizophrenia, their children, maybe we can intervene and address risk there. Unfortunately, the numbers that capture are also low. So about 7% of all psychotic disorders that arise in the whole population are in the offspring of parents who had psychotic disorders. So again, if we were to put all our eggs in that basket, we'll capture some of the cases, but we wouldn't capture all of them. We capture just really a very small proportion, as with the clinical high risk approach. Next slide, please. So this was applying what we call the transdiagnostic approach. So instead of saying, did you have a parent with a history of psychosis, we asked, did you have a parent who had an inpatient psychiatric admission for any reason? And the reason we wanted to look at that was that it's been increasingly clear that the risk for mental disorders isn't unique. If you have a parent with psychosis, that directly translates to a risk for psychosis. Risk for developing mental health disorders is quite heterogeneous across disorders. And so you may have a parent who had a history of bipolar disorder, who has a young person who goes on to have a higher risk of developing the whole range of mental health disorders. So we said, well, what if you looked at all all people in the population of Finland who had an inpatient admission. We looked at their offspring and followed them up to the end of their 20s, and found that in that case, it was about 29%, so nearly 30% of all cases of psychosis arose in the offspring of parents who had a psychiatric admission for any reason at some stage in their life. So a higher proportion there, still a minority. Okay, next slide, please. So taking all of that together, what does it tell us? And I think what it really tells us is that existing approaches to detecting risk for psychosis are limited. We're not going to solve the problem of psychosis prediction and prevention if we focus just on those strategies. And so we need additional approaches. We need to think about new ways. How do we identify people who are at risk of psychosis if we want to be able to intervene earlier, to predict, and ultimately prevent those disorders? And the question then, of course, becomes, well, where should we? Okay, if we're not looking just in clinical high-risk clinics, and we're not just looking at inpatient services and following their young people, their children when they're born over time, where else should we look? So next slide, please. Where we wanted to look was to look at a similar question was in child and adolescent mental health services. So what does a risk for psychosis look like in young people who come to child and adolescent mental health services? Only about 8% of all schizophrenia cases are diagnosed before 18, and what we call early onset schizophrenia. And so it's a small minority of psychosis cases that are diagnosed and treated in CAMHS. The vast majority have onset in early adulthood, and so are diagnosed and treated in adult mental health services. But if we could follow people over time, if we could follow the young people who come to CAMHS over time, would a substantial proportion of future psychosis cases emerge in that group? Because that would tell us, are there opportunities for prediction and prevention of psychosis in CAMHS, and to what extent would that be the case? And so we have these data-driven answers to the clinical high-risk approach, to the familial high-risk approach. What about CAMHS? What kind of percentage would we be talking about there, and how would it compare to existing approaches? I think CAMHS is also really important because you're capturing people in childhood and adolescence, and we know that is a really important time for intervention, for early intervention, for true early intervention if you're intervening in childhood. So next slide, please. And to do this, again, we use Finnish healthcare register data. These are really difficult questions to answer. You can't, why haven't this been answered before? Well, it's really difficult to follow a huge sample of people who come nationally to your child and adolescent mental health services and see what diagnoses they develop over time. It's not really very realistic, except with the advent of healthcare registers. And as I said, almost every healthcare contact in Finland for specialist care is captured. And so it means we could start to look at this once the registers have been established long enough to follow people from childhood to adulthood, which now, fortunately and excitingly, they are. And so we linked healthcare data on everyone born in Finland in 1987, and we followed them all to the end of their 80s. We followed them all, the 1987 cohort, we followed them all to the end of their 20s to see who developed psychosis. Next slide, please. And this is just, there's a map of Finland. There's some of the registers that we linked over time. Kind of like the Chi number here in Scotland, they all have a unique identifier that meant we could identify who'd been to health services and link it to the medical birth register, to Statistics Finland, to a range of healthcare registers that allowed us to follow these people, young people, over time from their childhood to the end of their 20s. Okay, next slide, please. So what did we find? This paper came out about 2 years ago now, and it was about what proportion of all schizophrenia spectrum and psychotic disorders, of the proportions of all of those diagnoses in the whole population, what percentage happened in patients who had been to CAMHS at some stage. And as I told you, that was a very small proportions, 4 to 14% for the clinical high-risk approach, 7% for the familial high-risk approach. And I'll show you what the results were for CAMHS. Next slide, please. It was 50%. So half of all psychotic disorders that emerged in the population by the end of their 20s were in people who had been to CAMHS at some point. And so what does that tell us? I think it tells us that actually there are very large and important opportunities to identify earlier stages of risk for psychosis within existing child and adolescent mental health services. And that we can see that risk is being captured just by virtue of the pathways that lead people into CAMHS. And of course, CAMHS concentrates and captures risks from a whole range of perspectives, from child and adolescent mental health problems. Lots of social determinants of health are enriched in CAMHS and so on, that are probably the reason as to why so many cases are there. But the point is that a large portion do come, and that's an exciting opportunity that I think we need to capitalize on. Next slide, please. What about the UK? So you might be wondering, okay, so that's great, that's Finland. Is that also the case here? Could it be the case here? There are some similarities, but there are also differences between Finland and the UK and between health systems. So that's something that we've been working on to try to figure out here. There are some really great data in the UK, of course, as well. The SAIL data bank is a similar national registry for Wales. Scotland has fantastic data. Unfortunately, it's not so easy to capture at the moment who has been to CAMHS. In SAIL, that is possible to capture it. So this has been a huge piece of research that's been led by another postdoc in our group, Chris O'Hare, that is not yet published, but has been looking at a similar question in Wales. So if you look at everyone diagnosed with a psychotic disorder in Wales, and you can trace them back over time, what proportion have been to CAMHS. And so I'll show you the results for that. So next slide, please. And so in Wales, it was 45% of all psychosis cases followed up to as far as 32 years old have been in people who've been to CAMHS at some stage. And that's really exciting. So it's really exciting for us to see, okay, if we are capturing this risk early, it's not just true in Finland, it's also true in a totally different health system. It's true here in the UK. A large proportion come. The small pie charts that you see up there are in the dark blue, you see, just for comparison, the proportions of cases that are captured in familial high-risk services or clinical high-risk services, which are, as you can see, quite small compared to the proportions that we capture in CAMHS, which we weren't really aware of until now, thanks to these registers and data-driven approaches. Next slide, please. So although we see a small proportion of psychosis cases in CAMHS post the diagnosis, we see a substantial number of cases before they develop psychosis. In fact, the median time to developing psychosis to being diagnosed with psychosis for the CAMHS patients was 6 years. And both as a clinician and as an academic, what that says to me is that that's an intervention window. That's a period in which we could intervene to prevent psychosis or reduce the risk of poor outcomes. I also mentioned briefly about this, that adolescence and childhood are, of course, key periods for development, including brain development. I have a picture there about synaptic pruning, but what that really refers to is, that is the snipping that goes on of our brain cells, and it's a key reorganization of brain wiring that happens in adolescence. And we know that is implicated in schizophrenia, and if we want to prevent psychosis, we're probably need to intervene during that stage. And what's exciting about CAMHS, of course, they are still in childhood and adolescence, so the opportunities to intervene are immense at that stage. So next slide, please. So I'm just going to wrap up. I'm coming to the end of my time, but just say a little bit about what I think that all means. I think that CAMHS is really important to the next generation of when we're thinking about early intervention of psychosis. And so we just didn't know that so many cases or future cases came to CAMHS before now. We do know that now, and that means a new focus on psychosis in child and adolescent mental health services. Of course, there's tons of research still to be done here. This is all really recent research, some of it not even published yet. We need to try to figure out, can we identify within CAMHS who's at greatest risk? That's one of the questions that we need to look at. How do existing interventions that we deliver in child and adolescent mental health services impact on psychosis risk? Again, that's a new question, and we don't know, but that's going to be important to look at. And of course, what follows from all of this is, can we reduce that risk, and what interventions might be helpful for that risk? Next slide, please. I'll just mention what we're doing here in Edinburgh. So in addition to the register-based data-driven research using large-scale Finnish register data, UK register data, Danish register data, we're also doing clinical studies, so directly recruiting from child and adolescent mental health services to better understand trajectories over time. Who goes on to develop a severe mental illnesses like schizophrenia, and how could we have identified that earlier? And I hope that we'll be able to provide some answers to those questions, but for sure there's still a lot of work to do on that. Next slide, please. And of course, there's a lot of people who've contributed to that, so I just want to acknowledge that as I finish up some of the key people who've contributed to this research, and the funders who have made this possible. There's not enough research going on in this area, but thank you to the funders who made the research that we're doing possible. Thank you.
Thank you so much, Ian. I can see you're getting some virtual applause. It's always very difficult in a virtual room to receive feedback immediately, but you are definitely getting lots of virtual applause and lots of questions coming into the chat. For people who have questions, I can see lots of people putting their hands up. We'll be taking questions at the end of the next presentation, but it was really interesting, Ian, and I particularly appreciated that you ended on, for sure there's a lot more work to do, and I think that is very definitely the case, and we'll definitely want to pick that up along with the really pertinent questions that we've got in the chat. So thank you. We will come back to you shortly. Thank you very much, Ian. And thanks everyone for listening and for responding there in the chat, and we'll come to those questions shortly. I am now delighted to introduce Ruchika Gajwani. Ruchika is a Senior Research Fellow in Clinical Psychology in Greater Glasgow and Clyde and at Glasgow University, and has been working with young people to understand how we can improve pathways of care for young people with borderline personality disorder. And you'll see that we've really tried to look at early intervention alongside young people, alongside understanding better our current systems of care so that we can assess both risk, design and improve outcomes for people, whether that is for children and young people or for adults. And I think Ian really touched on that through his presentation, and I know that Ruchika's presentation will also do that. So thank you very much, Ruchika. It's great to have you here with us today, and I will hand straight over to you. Thanks.
Good morning. Thank you for inviting me today to share the work on early intervention and prevention with young people with borderline personality disorder symptoms or features. My name is Ruchika Gajwani, and I'm a Senior Research Fellow and Clinical Psychologist at Glasgow University and within NHS GGC. I have a passionate interest, both clinically and in research, in understanding models of prevention and early intervention for young people. In the last 10 years, I've been focusing, along with others in Glasgow and in Scotland, to understand care pathways for adolescents and young people with complex unmet needs that are characteristic of borderline personality disorder symptoms. Before sharing the evidence and data on the impact of borderline personality disorder, BPD, on individuals and families, especially when left unsupported, is for us to hold, as someone with lived experience or a family member or indeed a clinician, that there are real stories and struggles behind these numbers. So this young person says, I have to keep a secret because people say, don't be friends with someone with BPD because they're manipulative attention seekers. They might not want to be my friend or date me, which hurts because I'm trying to get better. It's not my fault. To receive a diagnosis of BPD, the DSM diagnostic criteria specifies that an individual, a young person or an adult, would have to present with long-standing patterns of instability. And by long-standing, they are indicating at least for 1 year in areas such as interpersonal relationships, difficulties with self-image or self-identity, in mood, as well as marked impulsivity. With this, we know that there are around 256 different combinations of symptoms that would lead to a diagnosis of BPD. So there's an extreme variability in presentations amongst the individuals that we would meet presenting with these difficulties. And sometimes that can be seen as challenging because it creates perhaps amongst staff a gap in understanding of what really they are identifying or assessing. But what is clear is that BPD is a marker of severity in difficulties in functioning within oneself and in interpersonal functioning. However, what happens in clinical practice is that patterns of difficulties in areas such as self-image or chronic feelings of emptiness or indeed mood swings are not recognized earlier on unless the person is repeatedly in crisis or through self-harm or suicidal attempts. And that is when I think the diagnosis of BPD is considered, which can perhaps lead to further iatrogenic harm because we're not recognizing other symptoms that are maintaining these difficulties or contributing to the distress. In terms of the prevalence of BPD, we know around 40% of people attending psychiatric inpatients and 20% attending outpatients would meet criteria for BPD, but are being seen for other conditions such as eating disorders, psychosis, major depression, chronic anxiety. However, BPD features are left unassessed or unidentified. We also know in terms of those that would meet threshold criteria, there's around 1.1, but in terms of sub-threshold criteria, I think the prevalence rate's between 5 to 7%. But I suppose we all can also wonder whether through COVID, some of these incidence rates, and not just not prevalence, but incidence rates have gone up, as you would perhaps see in practice. What we know crucially is that BPD symptoms in themselves, whether left treated or untreated, will deteriorate over time. They will ebb over time. And this comes through epidemiological research, long-term research on BPD symptoms. However, what it impacts is severe functional impairment, so in the form of unemployment or seeking disability benefits, or multiple contacts with the criminal justice system. And quite crucially, and this is a really stark statistic, is that it impacts premature mortality. So, we have to really consider the impact of those distressing symptoms that young people present with. What we also know is that BPD is often, if recognized, it's in acute phases, when people are in crisis. And so we are repeatedly missing opportunities for earlier recognition. And where people would then present, if they fall out of sort of psychiatric care or clinical care, is presenting in other realms such as social or relational difficulties or within forensic services. And that really impacts, I would say, not just the quality of life for the young person and the family member, but it exacerbates health inequalities within the society. What we also know is that children with BPD have very poor transition from CAMHS to adult services. So just something for us to consider why young people are perhaps discharged without actually being identified for personality disorders, and why the transition to adult services is poor. One of the factors we know around BPD, one of the biggest factors and barriers for early identification and treatment, and perhaps even late stage, is stigma. It's just a hugely stigmatized diagnosis, which then creates additional challenge because we don't identify these difficulties, but it then perpetuates the cycle of these presenting difficulties for people. So, in brief, BPD among young people uniquely predicts severe and harmful current problems. It increases the complexity of clinical presentation and treatment delivery, and acts as a gateway to diverse and serious problems later in life in the form of functioning and impairment. Despite these compelling facts, along with good evidence that early intervention can improve short and long-term outcomes. BPD continues to remain a controversial diagnosis worldwide when applied to young people. This is largely because the condition is associated with a high degree of public, structural, and institutional stigma. This has commonly led to clinical cultures in which the diagnosis is avoided or delayed, or substitute diagnoses are used in the belief that this is in the best interest of young people. However, in turn, this leads to delays in effective treatment. It risks the use of inappropriate or ineffective treatments, leading to poor outcomes and further stigmatizing people living with these distressing experiences. We know that stigma in mental health, not just BPD, is perpetuated by sometimes a gap analysis of what we are presented with. So in the case of adolescent BPD, there are widely held beliefs and myths such as personality is developing in adolescence, and therefore the long-standing patterns of difficulties that we're presented with in self-identity, for example, may be transient, that they would young people would grow out of it, so to say. But we know that is not the case because personality continues to develop well into adulthood. There's also a belief that DSM and ICD do not allow for a diagnosis of adolescent BPD, which is not true. It's always been part of the diagnostic manual. However, again, coming back to our earlier point around the recognition around crisis, which is then in late stages that we miss the earlier recognition of BPD features. There are also widely held beliefs that symptoms of BPD are perhaps better explained by other conditions, such as major depression, anxiety, and substance misuse. And whilst they can coexist, we know that's the case. There is diagnostic overshadowing because of the belief that BPD is stigmatizing and untreatable, which then creates this cycle of iatrogenic harm. There's also a belief that features of BPD are normative and typical of adolescent transitions. And that is not true. These are very distressing experiences that young people present to us with. And they continue to say that they have not been asked these questions before, that there wasn't an identification of difficulties in functioning, whether it's interpersonal or within themselves. In order to understand pathways to care for young people with complex unmet needs that are characteristic of BPD, there was a study that was funded between 2016 and 2018 by NHS GGC. And this was in line with guidelines being developed for adult services and pathways for BPD. So we went and spoke to clinicians within CAMHS, adult services, as well as some GPs to understand how they recognize BPD. Is it being identified? And we had over 115 referrals to the study in 2 years. Of those, 48 young people met criteria for BPD features. So I want to share the case study of James, whose name has been anonymized for this presentation. James was referred by his adult psychiatrist and CPN after multiple suicide attempts and psychiatric hospital admissions. He was presenting with anxiety, depression. They were also querying some psychotic features, and also BPD. Within the study, we did a developmental history using standardized assessments, and James recognized that he was seen for ADHD or assessed for ADHD by an educational psychologist in his school. But this was left unidentified and untreated, particularly in the context of foster care. And we see this quite a lot where there is foster care or trauma, indications of trauma, that we are not identifying other complexities that could be contributing to those experiencing. So James was seen as somebody with behavioral difficulties within his foster care, and unfortunately, this led to foster care breakdown. James was expelled from school at the age of 13, and sadly, he had multiple contact with the criminal justice system. What this really indicated to us was that there was over 8 years of untreated BPD, and there are several missed opportunities from different services for early identification and prevention, really leading to where James was at when he presented all services. So several missed opportunities for developmentally appropriate targeted assessments and treatments. Within the Pathways project, we were also looking at developmental pathways and mechanisms that contribute to BPD symptoms in adolescents and young people, with a particular focus on neurodevelopmental disorders as well as adverse childhood experiences. 78% of the participants met criteria for autism and/or ADHD. However, only 13% had a diagnosis. Whilst we weren't using diagnostic criteria, we know that NDDs continue to be underdiagnosed, particularly in girls and in the context of adverse childhood experiences. In consideration of developmental pathways to BPD, along with other health outcomes, we now know that children and young people with both neurodevelopmental difficulties and adverse childhood experiences are at a greater risk, at an increased risk of adverse health outcomes. None of this is reductionist of the human experience, but an indication of the complex interaction that can help us identify clinical risk earlier on. Based on our pilot work in Glasgow on the Pathways project, we got funding from MQ, which is a mental health charity for research, as well as Rose Trees Trust, to look at a feasibility clinical trial here in Glasgow to see whether we can engage young people who might either be hidden to services or perhaps be engaged with multiple services. And the trial is to see whether we can engage and retain young people with BPD features in a model of early intervention and prevention. To design this study, we've had lived experience experts and researchers, as well as youth advisory group, who've been really helpful in understanding the design of the study. So, for example, our youth advisory group helped us in designing our subway poster and making the language really accessible to different audiences. So we've had referrals from grandparents, from clinicians, from college counselors, from GPs. So how do we really make language accessible to different audiences? As well as understanding connections between different groups, so we can work on our engagement with our young people, because they come from different contexts. And crucially, we are also doing qualitative interviews with young people to understand what works and what doesn't work within an early intervention and prevention model. So just to say a little about the design of the study, we looked to recruit 40 young people from the community. 20 of those were randomized to bridge intervention, which I'll speak briefly about, and 20 to services as usual. Just to say, for some young people, services as usual might mean no services at all. So just a consideration for us.
For our pilot work, we spoke to 48 young people who were attending different mental health services in Glasgow. These were young people who had problems that had been going on for a long time and whose services were struggling to find solutions for. Despite their high risk and the complex nature of their problems, we found these young people were actually less likely to be assessed or treated for their difficulties and often fell into the gap between child and adult mental health services. One of the young people in our study, James, whose name we have changed for confidentiality, was referred by his psychiatrist after repeated attempts at his life at the age of 25. In our interview with James, when we look back at his early life, he was known as early as age 5 by an educational psychologist for ADHD. He was unfortunately not given any diagnosis or support for this. James was expelled from school at the age of 13 and was in and out of different foster care homes, which he describes as quite traumatic. He was involved in the youth justice system at the age of 15 and unfortunately got involved in some serious violence. James found his mental health got worse in and out of prison services. He was not attending any mental health services until he attempted suicide, when he was referred by A&E for a psychiatric service. James had over 8 years of persistent mental health difficulties, which were identified as borderline personality disorder. Sadly, there are lots of young people in Glasgow and around the UK that are regularly missed from services and are left untreated. We know that for some, this can increase their risk of unemployment, being on disability benefits, being estranged from families, and sadly, high suicide. The Bridge study in Glasgow is hoping to identify young people like James in the public much earlier so there aren't missed opportunities. We are not trying to diagnose young people. We just want to learn how we can offer the right help and the right support early on.
Drawing on the model of early intervention and prevention for BPD, the Bridge project recruited young people on the basis of sub-threshold and full threshold BPD. So there is robust evidence to show that young people meeting even one threshold symptom of BPD, if left untreated or unsupported, then that can impact long-term functioning. So we use the criteria of 3 or more symptoms, so young people meeting sub-threshold as well as full threshold BPD to participate in our study. Our criteria for exclusion was if someone had specifically BPD treatment, so not treatment for anxiety or depression, but specifically treatment for BPD. Of the 85 young people who consented to the study, 3 had treatment for BPD and were excluded. For our recruitment, we used a partnership approach with multi-agency teams. We spoke to community teams to understand early identification of BPD. We presented to college counsellors, to links workers, CAMHS clinicians, GPs, social workers, as well as advertising on the subway. And what came across from this work is there's a gap in how BPD is being assessed and recognised. This is very much in line with the findings from the Scottish Government-funded Personality Disorder Improvement Programme, where staff spoke of gap in skills in identification and treatment of BPD. So just very briefly in terms of the Bridge intervention, we use principles of cognitive analytic therapy, which is a relational psychotherapy, working with our multi-agency partners to understand the unique context of our young people. So for one young person, it might be that they're not engaging with anyone, and we're using an assertive outreach approach to understand how we can work with them. And for another, it might be that we work with a CAMHS clinician, with a social worker and a college counsellor. And for a third, working with a foster care and schools. So our youth advisory group felt very strongly about school engagement. They felt that school can provide a source of stability, and where there is school exclusion, we really should be supporting children and young people going back to school, along with other functional outcomes in terms of vocational training, in supporting it. And that's been a huge learning for us. Within the Bridge intervention, we were also offering up to 16 sessions of cognitive analytic therapy. I would say there's actually good evidence for DBTA, for MBTA, for actually good clinical care. However, we know that is currently only provided to very few. Our pilot work also showed that actually comprehensive assessments are crucial to understanding the unique needs of our young people. We're in the process of completing data collection for the Bridge project, and I want to share with you some of our preliminary findings. On the right-hand side is the Bridge website, which was crucial for our recruitment and engaging directly with our young people. What has been evident through our initial analysis is that functioning was impacted in both those presenting with sub-threshold as well as full threshold BPD. So there's no significant difference in the functioning impairment between the groups. It's across the board in the form of educational attainment or exclusion, strained family relationships, unemployment, quality of life, being markedly impaired and leisure. In terms of service delivery, this is really important because, of course, we focus on severity, but actually functioning is also an indicator of impairment, and those presenting with sub-threshold BPD were also impaired in different areas of functioning. We have also done qualitative interviews with our young people who participated and were randomized to the Bridge project. So one of the young people said, the doctor wasn't keen on it because I was 17. They mentioned the Bridge project and they said that there's not a whole lot that we can do for you. We can give you the medication and help manage your symptoms and sleeping problems, trying to keep the big mood swings kind of as small as we could get them with the medication, but there wasn't any other options available. And so they mentioned the Bridge project and were like, here's something, it's experimental. It might not work for you, but we'll send you on your way. Second young person spoke about falling through the cracks. So you fell through the cracks quite a lot of the time. And the guy, he was lovely, but it was just very much tick box exercise. I don't feel like there was much, even the substance, in any conversations we had. There was only ever crisis support, never like any therapeutic work. It was always kind of just assumed because your mum and dad are drug addicts, and abandonment and just attachment. And that was like the first kind of thing that they seen that was happening. But there's much more, if everybody would just ask, obviously. In sharing the young people's experiences, we recognize that lived experience voices are crucial to understanding where the gaps are in our services and how we can support staff, families, young people in our communities in making better connections so we can provide better services and reduce health inequalities. Whilst we are considering change, something for us all to hold is the systemic burnout. We're all told to work harder, yet the public health services have been systematically eroded. Ironically, the previous government commissioned work and found that 80% of NHS and social care services in the UK spoke of staff burnout. What can be useful is a public health approach to prevention and early intervention. So we can support our community-based partners, teams in assessing and identifying complexity. So specialist services can also support some of the most marginalized young people. And this is very much in the context of other work happening in Scotland around infant mental health, the Personality Disorder Improvement Programme, the neurodevelopmental service development, and the complex cases pathways. So this really sits within a care model where physical health can also meet medical health and social care. And really at the heart of this work has to be lived experience, expertise, and voices where they would be key to reducing, I think, redundancies in service delivery and design. In terms of the next steps, and this is my final slide, is our endeavour for Bridge 2. We are working on mapping and modelling current service pathways for early intervention and prevention for BPD in 2 other sites, in Ayrshire and Arran and Grampian, and continuing the work in Glasgow to build relationships, infrastructures to support a multi-site trial, to improve and understand how we can improve pathways to care for young people with BPD. I want to end by thanking the young people who've participated in our studies, their families, lived experience advisors, researchers and clinicians who have collectively worked and continue to work on improving care for some of the most vulnerable children and young people in Scotland. Thank you.
Hi, so thank you, Ruchika, for that a really fascinating and interesting presentation. We are aware from the chat, obviously, that some people had issues with sound and there was a slight glitch with the playing of the Bridge project recording. To enable to be accessible for everyone and to be as inclusive as we can. That was actually a pre-recording that we did with Ruchika to enable her to be here. She was live for our Q&A later. It did mean it limited our options because obviously we couldn't, we turned up what we could as loud as we can, and we had tested it before, but it obviously plays differently on different machines. So that's some learning, some continuous improvement for us to take away and understand how that sounds on different machines, and it also is what's caused the slight glitch in that video dual recording. So I really apologise for any inconvenience that caused you. As I say, we'll take the learning on how to make it better, but in the moment we had both the sound on the video turned up as loud as we can and tried to mitigate it as much as we can. The recording will be available at the end, so you can listen to it, and hopefully on that you'll be able to turn it up. And we'll also be able to put out Ruchika's presentation and the video that was contained within Ruchika's presentation as separate links as well, so that if it's linked within that. So I appreciate your understanding for us trying to make sure that Ruchika's presentation could be here with us today, because as you'll agree, it's some fantastic content. So we'll make sure it all gets to you. She is here for the Q&A, and thank you for understanding. So I will now pass over for the polls.
Thank you very much. Thank you, Diana, and thank you, Ruchika, and thank you everyone for being part of that that presentation. We are now at the point of the webinar where it is over to you. So we have polls, then we have question time, so we need to hear from you. We recognise that staying with us to hear the presentations and then getting involved in the Q&A might not be possible for all of you, so we would really appreciate your input into the poll so that we can continue to meet the needs that you would like met through things like this learning system and this webinar series that we've got going. We've got lots of questions and comments in the chat, and I'd also like to thank you all for being so present and so curious, both about the speakers and the presentations, and also about the experience of the webinar. I think you've all been so involved in describing your experience, the sound quality, supporting each other, trying to work out what else is going on in this virtual room. I've found that really heartening, because it's not the same, this, as being in a big room together in real life. But in terms of the comments that we've had coming through, it's been really amazing. You've been a really amazing virtual room. So on that note, we would like you, if you can, to get involved in the polls. I think we've got 4 or 5 questions, and you'll see them popping up on your screen. You just answer them. There's 4 questions. You just answer them, and then we can gather that feedback live from you. So please do stay for the next 30 seconds, answer the questions, and then we'll go over to the Q&A. Okay, thank you. I will pause at this bit, but I'll keep my camera on. Okay, I can see some responses coming through, so that is great. And if I look at the second question around the word cloud, about learning people are taken away from today's event, we can see early intervention in the middle there. We've got CAMHS, we've got early support, we've got better understanding. Really great words coming through there. And I'm glad to see that lots of you would recommend these events, and that this did increase your understanding of the importance of early intervention in reforming mental health. So as we go, as people are just finishing off and making their final comments there, I'm going to hand over to Susie, who's going to facilitate the question and answer session. So if you've got new questions, pop them in the chat. If you've got comments you want to make, pop them in the chat. We would love to hear from you at this point, and I know that we've got a number of questions already that are themed across the presentation. So Susie, over to you. Thank you.
Thanks, Rachel, and thank you, Ian and Ruchika, for these presentations. I think it's really helpful to have a focus on young people, I guess, and how much development gets derailed when they have complex mental health issues presenting. There are a couple of questions, first of all, for Ian, really around about psychosis. And one of the things that came out on the chat, I'm sure you saw, was the sort of overlap with neurodevelopmental disorder. And that's obviously something that's seen a lot of in CAMHS, and people really asking, maybe is that the group that went on to develop psychosis, because there is overlap, and there's certainly, I know in Esteem we have quite, reasonable comorbidity, probably about 15% people with ASD, and so that was the first question.
Yeah, so I think all of our expectations going into this will be that you'd expect neurodevelopmental disorders in particular to be associated with an increased risk. So going into the study, we thought, well, autism and ADHD, we're probably going to see higher rates there and lower rates elsewhere. What really surprised us was that wasn't the case. So the rates were high across the board. And it really didn't matter what you came to CAMHS with, whether it was a depressive disorder, an anxiety disorder, an eating disorder. The rate, your risk was increased. It was increased for autism, but it was also increased for ADHD, but it was also increased for depression. And so, so it's not something unique to autism. One of the things I do often point out, though, when I'm asked to see young people with a query around psychosis, is I'll get a referral request, and it will say, someone has such and such unusual perceptual experiences and overvalued beliefs, but they have autism. And I do always try to make the point of it, and they have autism, because autism does not reduce your risk of developing psychosis, it increases your risk. But what's ultimately interesting from this was that coming to CAMHS for any reason was associated with an increased risk, and that certainly wasn't just limited to autism.
That's interesting. That's interesting. The other kind of 2 points, really, people just talking about clinically how difficult it is to tease that group out and work out what's psychosis and what's autism, and I understand these are complex kind of diagnostic questions. Another point was around how CAMHS can lower the risk of psychosis. So there might be shared pathways that underpin the risks of psychosis and BPD, but CAMHS themselves are under massive demand. And is there things that they can do to reduce the risk of psychosis, do you think?
Yeah, so I mean the short answer is no, because I'm very evidence focused, and I think lots of people have opinions about what might reduce risk. I'm always someone who will say, show me the data that it does that, and we need to look at that data. So the findings are really new, looking at the level of increased risk and what proportion of people with psychosis come to CAMHS. So the research just hasn't been done yet. We're working in our team with some promising results. Hopefully I'll be able to share in the coming year or so, but we need evidence on that. We need research, and we don't have it. So it was just in 2022 that we've published those results from Finland, and like I said, the UK results aren't even published yet. So the trials haven't then happened. I guess the interesting is looking at other risk approaches that have been around for longer, like the clinical high risk approach. And there have been things that have looked potentially promising, but that haven't come to fruition when you look back systematically to see what can reduce risk in clinical high risk. But there have been very few trials, is the truth. Less than a dozen interventions have been trialed. I often talk about, I worked in a stroke team before I came into psychiatry, and more than 1,000 pharmacological agents had been trialed to prevent poor outcomes in stroke. So we're talking about very small numbers of interventions still being trialed, which means we need a lot more research in this area. CAMHS has been really, really under-researched, and that's why we need much more of it. So the answer is we don't know now what can reduce it, but we're working on it.
We're working on it. Okay, that's really helpful. I guess there was another point around about, diagnosis is not always that helpful in terms of, diagnosis is not necessarily all that helpful in terms of understanding a young person, because their complexity often needs a kind of formulation or a sort of whole systems approach. But sometimes you need these early diagnoses to open gateways into treatment and other services. So I think clinicians wrestle a little bit with that, that complexity, and how do you put that across in such a way that you can access services? And maybe that needs to change. Maybe there needs to be more of an understanding of the complexity, because the diagnosis is not always clear, but it doesn't necessarily mean that there's no demand or need there. I guess what our results underpin is a maxim that we often use in child and adolescent psychiatry and CAMHS, is that we write diagnosis in pencil rather than pen, because diagnoses do change over time. But I would say at the same time, that doesn't mean you can't identify the diagnosis that's present now. And I think that is really important. I think, it's both diagnosis and formulation are really important, because if you don't diagnose psychosis and it is present, you're not going to treat that psychosis. And people can have years of untreated psychosis, and I don't need to tell this group that is associated with really poor outcomes. So both are important, and that sort of ties back in some ways to the autism piece, where someone will say to me, but they have autism, and I'll say you're formulating away the diagnosis, and that's a problem. If they have, they may have both. And to Ruchika brought up the idea of diagnostic overshadowing. I think that frequently is a problem in autism. That you have to come back down to what do I do when I'm asked about these complex cases. I use things like structured or semi-structured tools, things like the SIPs and the CAMHS to really drill down and try to figure out what is going on for the young person, because I know that untreated psychosis will lead to a bad outcome from that person, and I don't want them to be one of those statistics that I showed you early on of people who are spending extraordinary amounts of time of their lives in hospital. So getting the diagnosis right is really important. Yes. I think one of the other comments that's come up is really people feeling that CAMHS is such a catch-all for everything, and actually services need to be focused on people who have greatest needs with the evidence-based interventions to support them. And there's issues around there aren't necessarily other support services around, so it becomes a bit of a catch-all, and then staff become overwhelmed, and that kind of refinement isn't happening so much. There was also a comment about CAMHS maybe needs to extend up to 25 or into mid-20s, because it's taking a while for these young people almost to be identified, and then they're changing services, and that learning all starts again, and that transition can be quite challenging, as we know, between CAMHS and adult, and then that's another opportunity missed for kind of early intervention.
Yeah, and it certainly highlights at the least the need for better integration of services and more continuity of care, and better approaches around those transitions. But also, I think, coming back to your previous point, Susie, I think that, not just in CAMHS and adult mental health services too, that you can't actually be an expert in absolutely everything. You can't know expertise levels about psychosis and how do I move to, between the different treatments, get to cause for treatment, and then also be a complete expert in eating disorders, and then also happen to be a complete expert in ADHD. And, so I do think we do need to develop more specialist streams within our services.
Yeah, that's helpful to hear, actually, because I think some of these clinical conditions do require expertise to maximise outcomes, recovery, and there isn't a one-size-fits-all, is there, for people with complex needs? And it's so sad when you read these pathways that we've all read clinically, and these opportunities that have been missed, and these young people who can be disillusioned before they even get to adult services, that services have nothing to offer them, and so they don't ask for help. And it's worrying that that's what happens, but I think it does. I think it does happen sometimes. There's a few questions around about the Bridge 2 work, Ruchika, and whether that could possibly extend to other areas of Scotland.
Hi, can you hear me, Susie?
Yes. Thank you.
Okay, I just want to start off by apologising. I thought I'd be really organised and recorded earlier, so maybe there's a parallel process here of BPD voices, getting, I don't know, lost. So thank you for your patience. But in terms of Bridge 2, absolutely, we've had some discussions with colleagues who were working in Glasgow and then are now in Ayrshire and Arran and Grampian, but this is about feasibility work. We're also partnering with Personality Disorder Improvement Programme, which is Scotland-wide, in identifying different sites to do some of the pilot work before we have a definitive trial. So very happy for anybody to get in touch to see how we can do pilot work as well as more sort of broader mapping and modelling.
Thank you, Ruchika. That's great. I'm just going through the comments. There is definitely a few people saying that there's a much greater need for bridging services from CAMHS to adult services in Lothian. I know the interface can be really complicated in Glasgow, partly because there's so many different services and they might have different pathways or different contacts, and that can be tricky. And there's a few more comments in there about how can we prevent the need for CAMHS, because there seems that the demand's so high and there's no alternatives out there. So there's maybe something about third sector work. Yes, are there any national plans for developing better CAMHS data sets that capture the presenting symptoms more systematically? Is another relevant question, I guess, given that we're looking at mental health. I know that's adult, but mental health standards for services and mental health outcome framework for adults. I wonder if there's one being developed for CAMHS as well.
Yeah, so it really depends where you are. So what we need to do to, I think, have intelligence-informed developments in our services is that these things happen at a national level. And so at some local levels, you can capture information directly from clinical notes, for example, in Lothian, thanks to DataLock, one of the resources. But this needs to happen at a national level to be really usable. So there is a lot more work needs to be done around data accessibility. So it's used to the same extent that people in Finland and Denmark and Sweden are able to use their registers.
Yes. Yes, I mean the data I know from some of the work that we've done, there's definitely, it's not all joined up, is it? And you can find pockets of data, but you can't find national data, and then that maybe limits what you say. There's a comment around about how useful it would be to have tier 2 services for children and young people as a kind of vehicle almost for identifying those most at risk of complex mental health conditions. And I think that is something that's been considered at times, but I'm not sure where it is in terms of development now.
I'm happy to say a little bit. I completely agree with the comments that are coming about in terms of how we leave it too late in terms of early intervention. Early intervention, of course, have been traditionally sat within specialist mental health services, which we know is crucial, but it's how they support services as usual, and particularly third sector, college counsellors, GPs, links workers in early identification, so people aren't waiting to go into crisis to access services. There are trials and studies and work in elsewhere. So, for example, in Netherlands, where they didn't find any difference between MBT and service as usual, because service as usual was very good at sort of doing the care coordination work earlier on. And what that meant was it created a pathway for those with huge unmet need rather than this, gaping hole. So I completely agree that we need to support teachers and social workers and GPs in recognizing difficulties earlier on. And that is really part of our work in Bridge too.
That's so interesting. I mean, I increasingly feel like there needs to be some kind of public health campaign around about mental ill health and mental well-being, and that actually trying to discriminate that and when to seek help and how much is about what can be offered from third sector and about maintaining well-being. And actually, but I think it's a risky or it's a difficult thing to think about strategically, because services already are under huge pressure, and the idea of maybe just increasing awareness or whatever, but it feels like some kind of public health campaign focusing on young people would be very valuable for all this work that you've spoken about this morning. But it's about how is that met in services, and how does that get picked up? It's quite difficult to, it's a difficult time, I think, at the moment, isn't it?
But in terms of health economics, Susie, you're completely right. I think it would really save costs within the NHS if we can work with that public health approach. It's going to take a while, but we've seen within Bridge, actually, it's paid dividends to be working with teams around the young person in improving care pathways. And we've got data from elsewhere where having that public health approach really supports young people with the most unmet need. So it would help clinicians as well as people in having that early identification prevention model. There's a beautiful article that was published by in Finland, actually, called The Finnish Miracle, and they found over 10 years of sustained public health approach, they found a reduction in rates of suicidality, and then it's just really telling how it can pay dividends in having that public health approach.
Yes, no, I think that's really helpful. I know my colleague Nathan in STEAM has also talked about, teachers in secondary schools or ed psychs or whatever often being on their own with really quite complex young people who are not engaging with traditional health systems, but then are on a trajectory for developing more serious illness. So yes, and then some suggestion that we should be focusing entirely on well-being and scrapping everything else. So there's lots of comments coming in. It's good that people have engaged so much. Andy's also made a comment here about the availability of data being a particular challenge for any personality disorder development, because there's often underreporting of diagnosis, perhaps stigma, and also around about maybe needing more education and spotlight on this patient group, which I would agree with. I mean, I think there needs to be public health, and certainly for early psychosis, the people are often have quite multiple help-seeking attempts or contacts with services before they come to us. You know, some people who've been seen by CMHTs 3 or 4 times, or 2 or 3 different referrals, and they're still, the psychosis is not being recognised, and it's very devastating for individuals when they've, you know, maybe had a DUP of a year despite trying to get help. We've got a comment in from the Mental Health Intelligence Team in Public Health Scotland. Have developed a patient-level data set called Child and Adolescent and Psychological Therapies National Data Set, the CAP-TND, which does have the capability to record the reason for referral and diagnosis, and we're currently working on adding presenting problem. The data set is still in development, so data completeness and quality of the items are not where we need them to be at the moment. So the work's ongoing with boards, but recently published findings using the data set, and this can be found here. And there's a link to Public Health Scotland there. So that's really useful. Thank you for posting that very much. That's really helpful. That'll be interesting for our audience. And there's Louise come in and said that there's a bit less stigma for BPD held in CAMHS as compared to adult. So that's interesting to hear as well. Okay, anybody got any other questions for our speakers today? No, there was one final point I was just going to, oh, Michelle, sorry.
Sorry, I didn't get the time to type it in there, but just a question to the speakers about how all these important things we're talking about this morning can translate to general staff training and culture change in our services. I feel we've got a captive audience here of people who believe early intervention is important and believe like diagnostic labels are important. And we also find with some of the PDIP, personality disorder improvement program work that we've done, just the difficulty on the ground with some of these concepts, and also what you were talking about, the staff burnout issues, Ruchika, and yeah, just how the importance of early intervention can be highlighted in our standard work with helping staff to gain skills to work with these populations.
Yeah, well, from a psychosis perspective, one thing I would say is that additional training on, I mean, we were talking about, you know, recognizing more neurodevelopmental conditions in adult mental health services. There's a big focus on neurodevelopmental, of course, in training to be a child and adolescent psychiatrist, and all CAMHS clinicians have a lot of training on neurodevelopmental conditions. On the flip side, there's a lot of training on psychosis in adult mental health services and a lot less in CAMHS services. And so I think that part of what the data that I presented shows that actually we need to be a lot more aware of the risk of psychosis in CAMHS. For sure, most of them just did not have psychosis at that time. They went on to develop it much later. But some of them, I have no doubt, did have psychosis even when they were in CAMHS, and it was not recognized at that stage. And so the importance of recognizing it, it means more specific training on psychosis, including that challenge around how do I separate this out from complex other neurodevelopmental conditions, including autism. I think ultimately, though, it's not, like I said, it's not realistic for everyone to be expert in everything. And I think this is why, you know, if you're a surgeon, you're expected to have X number of cases that you deal with on an annual basis to be considered competent. If you are working in CAMHS and you have a small, relatively small throughput of psychosis cases, can you really be expected to have the level of competence that would be there in psychosis as in adult mental health services? And so I think it's really an indication that that specialist psychosis services are really needed in CAMHS as well as in adult mental health services.
That's helpful, yes, thank you. There was another question that's coming around about learning disabilities, and actually both psychosis and borderline personality disorder are being diagnosed a bit more readily in learning disabilities, and whether that was being captured in either of the studies that you had talked about.
We didn't have very many referrals actually from Learning Disability Service, so I am really, really intrigued to hear that. My sense is that actually the recognition of BPD and BPD features is hugely underdiagnosed or under-recognized. So I'm actually really curious to see the data or have a conversation where that's happening, because our sense from the work we've done is that actually BPD continues to be hugely under-recognized. And Ian, I was really curious from the Finnish data that you showed that the box for BPD is actually really small in comparison to the others in terms of prevalence or incidence, actually what's being picked up. So we know it's highly prevalent across different sectors. Our pathways work showed that people are accessing different services that would meet criteria, but it's being under-recognized. I don't know, Ian, if you could reflect on that.
Yeah, I mean, there's so much you could say on it. What would I say in a nutshell about it? I mean, I think that if anything is open to early intervention, is going to work. Surely disorders of personality development are. And so that's why I think it's so important that this research is being done. Because, as with psychosis, I mean, I talked about some of the neurobiological changes in terms of synaptic pruning during adolescence that we know underpin the development of psychosis. The factors that underline the development of borderline personality disorder. Of course, it makes sense to get in early and treat those. And so I think we absolutely do a lot more research in that.
Yes. Thank you both very much for such enriching, rich and interesting presentations this morning, and really helping us to focus in on complex young people. I just want to end just to draw attention to Hamish's comment that's in the chat box about maybe reform is needing some kind of advisory panel with describing a diverse experience advisory panel, and that might be a good way to take forward our lived experience expertise in HIS. Thanks very much, Ian and Ruchika, and the audience for participating in the questions. It was a really interesting morning, and I will hand back over to Rachel at HIS. Thank you.
Oh, thank you, Susie and Ian and Ruchika. It's been great to hear that question and answer session, and you can see in the chat you're getting a lot of thank yous and a lot of people really interested in the things that you are experts in and the things that we've brought together today. So if I can get everyone to do a virtual round of applause. I know we can't do an actual, but some small yellow hands would be great. We've got lots of hands up now instead of applause, but that's fine. So thank you very much, and thank you, Susie, for facilitating that and for keeping everyone who wanted to be brought in. And Hamish, thank you for your comment about bringing in a diverse range of people around lived experience. It's something that we're talking about across the whole, not just reform, but reform and standards, and extending into our understanding around assurance. So it is something that we were picking up, and I know we're picking it up with some of the organisations, Hamish, that you're familiar with. So that's great to hear from you as well. So on that note, I'm going to hand over to Diana to close the session and to bring us full circle, I've no doubt. Thank you, and over to you, Diana.
Thanks, Rachel. And though we're in very different virtual spaces, I think you've read my closing notes and my summary remarks. I just a huge thank you. It's been a very enriching morning, and I think it has given me heart that the work that we're trying to do in reform about recognising that complex, diverse space and creating spaces for these conversations feel really important, and I'm glad, and I really appreciate everybody who's been here and their engagement with the speakers and the content that they brought, and we'll commit to doing more of this. As I said earlier, everything will come out. We will make sure Ruchika's presentation comes out separately. Recording comes out separately, as well as with the bridge video. So you've got that. The whole recording will be there, and we will send you the dates for the future ones, and hopefully with that similar tone that, you know, this is relational work, and being relational even in digital spaces is really important, and the kindness and compassion that you've showed us is really important. I really want to extend that kindness and compassion, if you can, to Rachel and Nicola, who were behind the scenes working really hard and trying to manage all that glitches, and unlike doing it in the olden days where you were together in a room and you could give somebody a hug, if we can send them both a virtual hug, because I know it would have been incredibly stressful for them. A huge thanks as well to Ashley and Gordon, particularly Ashley, for pulling all this together for us today, and making and helping us to deliver this reform programme over the coming period. So as we be relational, as we think about our roles as leaders across and holding the hands across systems to minimise those gaps and bridges and silos, and maximise the bridges, then I will leave you to get on with your day. So thank you all very much.